Mic check. Thank you for coming to the session, and we are very sorry for starting so late, but we'll make it a bit more interactive, interesting, as much as we can. This is a session on managing climate-sensitive infectious diseases, risk and pandemic preparedness. I'll be chairing this session. My name is Dr. Vincent Pagiwa, a health policy analyst and a public health research fellow at the University of Botswana. Ladies and gentlemen, the African continent has been warming up at a rate similar to the global average. Rainfall patterns has also changed, with a tendency to more variable and extreme rainfall, along with drying trends in key areas, especially Southern Africa. Projections from IPCC indicate it is very likely that the African continent will experience greater warming than the global mean. So we are seeing a high burden of climate-sensitive diseases, with the highest per capita burden of malnutrition and diarrhea, to be precise. And then the difference between the possible and actual health impact of climate change in Africa depends largely on actions taken today within health and other sectors. This means we need multi-sectoral collaboration to tackle this, as other speakers have said. So, ladies and gentlemen, this session today seeks to address climate and the burden of climate-sensitive infectious diseases using empirical evidence, best practices, and case studies from around the continent. So my panel consists of researchers and policymakers who will deliberate on those issues. So I will now introduce my panel, and as I introduce them, they will come to the podium. First of all, I have Dr. Charles Akatobi Michael. Dr. Charles is an FETP-trained epidemiologist and climate change and health enthusiast with 15 years of substantial public health experience. His expertise cuts across health practice, surveillance of and disease reporting, emergency preparedness and response, disaster risk management and mitigation, health and immunization systems strengthening, and health workforce development. With a dual master's in public health and disaster risk management and development studies, Dr. Michael was part of the presidential task force that responded to the COVID-19 pandemic in Nigeria. He recently works with Africa CDC as a senior technical officer and leads the Africa CDC Climate Change and Health Program in the Eastern Africa region. Let's welcome Dr. Michael with a clap of hands. Our second panelist or speaker is Dr. Julian Natukunda. Dr. Julian Natukunda is a postdoctoral research fellow at the University of Oxford and a member of the Chance Network Steering Committee. Her current work adopts a universal approach to understanding and developing actionable tools for solidarity practices on global health. Before this, Julian worked on the EU Horizon 2020 NBEL project, researching the impact of climate change on health and support policy engagement on health adaptation in East and Southern Africa. Her interests are centered on engaging multidisciplinary research initiatives that encompass disease prevention, health policy and equity, climate health adaptation, and knowledge translation. Let's welcome Dr. Natukunda. Okay. My next panelist is Dr. Didkas Namanya. Dr. Namanya holds a PhD in Public Health, Master of Science, Public Health, and BA Geography. He has over 20 years work experience with the Ministry of Health in Uganda as a health geographer and climate and health focal person. Dr. Namanya has participated in international research projects on climate change and public health, for example, indigenous health adaptation and climate change, environment change and adaptive capacity mapping, examining and anticipating future risk of water-related waterborne diseases in Uganda. Let's welcome Dr. Namanya. The next speaker is Dr. Tatiana Marufo. Dr. Marufo is a public health researcher at the National Institute of Health, Ministry of Health in Mozambique. She graduated in medicine and a master's degree in public health, and she's currently a PhD fellow in ecology and environmental health. Dr. Marufo has been a researcher over the 12 years. She has coordinated the Climate, Health and Environment Observation Platform and National Health Observatory, the Technical Secretariat of the National Health Observatory Unit, and ongoing coordination of the Environmental Health Strategic Forum, including occupational health at the National Institute of Science. Let's welcome Dr. Marufo. And our last but not least is Dr. Mohammed Ibrahim. Dr. Ibrahim is a veteran. How do you pronounce this word? Is difficult for me. Yeah. Veterinarian, that's what I wanted to say. Yeah, he's a veterinarian by training and holds a PhD in epidemiology from University of Basel, Switzerland. Dr. Mohammed has rich experiences in teaching, research, and community service. His work focuses on zoonotic diseases, prevention and control, and microbial resistance, food safety, and other One Health-related issues on One Health approach. So currently, he's the One Health technical lead at WHO Ethiopia Country Office under the Emergency Preparedness and Response Cluster. Let's welcome Dr. Ibrahim. Thank you so much. Now, I will allow my panelists to break the ground with a 5-minute presentation each, and then later on, we'll now dive deep into the discussions. I'll start with Dr. Charles.
Again, good morning. Okay. So, good morning, everyone. Okay. So, I think I'm happy to. It's a great pleasure to be in your midst, and I think we're in the right section talking about infectious diseases that are climate sensitive. Like I always tell my colleagues when we talk, we all agree that we need a multi-sectorial approach to addressing climate change impacts, especially at the health nexus. But what I've always held is that health is the face of climate change, because irrespective of the sector from which you approach it, the ultimate recipient of the overarching impacts of climate change is the human person. Whether you look at it from an agricultural perspective, or you look at it from the angle of the physical environment, the built environment, or the social environment, ultimately, it is either diseases or the well-being of the individual person. Remember also that when we're looking at health, we're not looking at it just from a diseased condition, but we're also looking at the well-being of the individual overarchingly. So the time is short, and I'm just going to run us through some of my discussion points, and then, of course, we can interact. Next slide. Okay. So I want to start by highlighting the fact that of over 2,000 public health events recorded in the last 2 decades in Africa, 56% of them have actually been exacerbated by climate change issues. Now, if you look at global trend, we know that about 23 million deaths annually is accounted for by environmental-related issues. In Africa, of all of those outlined environmental issues, infectious diseases are one of the key drivers. Whereas in other developed climes, non-infectious diseases and all other associated environmental determinants of health seems to have overarching scenario. But in Africa, we see a lot of infectious diseases. So you see things driven like cholera. You see, like currently we have the trending mpox. So overarchingly, in Africa, if we want to take care of our population, then we need to be able to deal with climate-sensitive infectious diseases. And that is why I felt like we need to understand what are those infectious diseases that are very prone or that are reoccurring in Africa. There are quite a number, but I've highlighted 3 significantly because these 3 almost covers all the regions of Africa. And you look at malaria, you look at dengue fever, you look at cholera. In the last 3 years or so, cholera has been protracted in Africa, in many countries across all of the regions. And we see climate-related issues like the El Nino impacting significantly the burden. And then we've seen also malaria incidences in hitherto malaria-free zone. In Kenya, where I work from, we've seen counties and communities which hitherto did not have malaria following the El Nino incidents are now battling with malaria. So we need to understand that we need to tackle infectious diseases as we look at climate-related issues overall. And I put up these charts to understand how climate impacts, climate determinants impact health issues. Now, recently, I came to understand that just a 1 degree change in daily temperature over time can actually exacerbate or increase the ability of malaria vectors to thrive in areas that they were not thriving. Just 1 degree centigrade change. And the overarching impacts usually are not measured from climate change perspective. Most times when people are measuring it, they look at it from clinical perspective, and that is the natural tendency of clinicians or people in the health sector. And that is why it looks like the health sector have not made significant inroad into the climate change discussions. Even when we go to COP, you find out that health is still significantly left out, despite the fact that from Dubai, we saw that there was a well-attended, high-level health day that had discussions with the communique, but in the final decisions, we didn't see health coming out clearly. And this is something we need to take note of. So a recent review showed that for climate-sensitive diseases, there are some of these environmental factors like temperature, precipitation, can exacerbate them by 60% sometimes in certain climes, and sometimes can facilitate their persistence in the environment. And in the long run, we're looking at human lives, we're looking at maternal and child mortality. And you know, epidemiologically, I used to tell my colleagues, when you say case fatality rate is 0.5%, it sounds so negligible, isn't it? But put that in the context of the population. So you can see case fatality rate of 0.5%, causing mortalities that are about 10,000 and above. And then you check sometimes to put it in perspective. Imagine how many planes needs to crash for 10,000 people to die. And then it will give you a mental picture of the magnitude of what we're dealing with. But many times, when we talk as clinicians or we talk in forums like this, we don't put this into perspective in terms of the effects of all of this. So because the time is short, I'm just going to look at broadly what we do to manage climate-sensitive diseases. Now, this discussion from me actually is going to tailor down on what we do currently. And maybe as we discuss, I'm going to profile what we can do going forward from this conference. One of the things we do currently, and which I would think are some of the innovations that have come over time, is the fact that we do what we call regional prioritization and disease mapping. In some of the regions, we've tried to prioritize epidemic-prone diseases. But suffice to say that in those prioritizations, climate change considerations are not critical criteria. And then so you prioritize based on clinical perspectives, epidemiological linkages, and all of that. You get priority diseases, and then you don't factor in climate change. Then you develop your programming based on those prioritized diseases. And then the climate changes, like we see, and then it totally takes you off. And that is why it looks like in Africa, the health system is continuously unprepared for climate emergencies, because these are not factors in our discussions. Now, we've been making concerted efforts to strengthen epidemic and pandemic preparedness activities across member states. I recall recently the Pandemic Fund just released the list of countries that were funded. And it's gratifying to note that more numbers of African countries are recipients now. And what we did, like I was part of the team. We went around the continent and we supported member states to develop proposals that are linked to a One Health thought processes, rather than the clinical perspective that we always try to address diseases from. Okay? And we need to be intentional about that. Now, there's also this perspective when we look at climate change. Somebody will ask you, how does it cause infectious disease outbreaks? But we should not only look at health from the causal perspective. There is also the response perspective. I've seen when we did immunization programming and we had immunization supplementary activities, you plan to do campaigns. You've mapped the population. You've done your micro-planning. Everything looks watertight. Your logistics are available. And then just the day before you go to the field, there's high rainfall, there's flooding. Populations get cut off. And then you thank you. Okay. So then we look at intensified surveillance. Now I'm saying that what we do currently, we do evidence-based surveillance, we do mortality surveillance, we do cross-border surveillance. But we've not integrated surveillance for environmental determinants of health, incorporated it into the health surveillance, and see how this interacts with all of the other surveillances we do. Now, we talk of development and rollout of disease risk prediction models. Some models have been developed. Recently, I saw some colleagues that came from University of Florida in Kenya, and we tried to work on how to use Earth data to model cholera outbreaks and be able to initiate preventive measures. All of these are currently happening, but how are we integrating climate change? Then, of course, we have improved early warning system, but most of those early warning systems do not incorporate climate intelligence. There is no proper linkage between meteorological information that are predicted every day with what we do epidemiologically, and that linkage needs to be done. Strengthening service delivery and case management. This is where we think we've made significant progress. You know why? Because we think like clinicians. We think on the disease that is presented on our decks or in our treatment room, but we don't think of the general impact to the public. And lastly, we've been a little bit more conscious in trying to entrench One Health approach. And I was very excited yesterday when the Vice President and the President of Zimbabwe were talking. They made mention of a National Public Health Institute that's anchored under the One Health approach. I think this is the way to go. But this One Health approach, I see also that most of the discussion is either environment and health or animal health and human health. But there needs to be that overall linkage of ecosystem health, human health, and veterinary health, especially because we're seeing that most of the diseases are becoming zoonotic in nature. And I just put this map to show you. This is an extract that we did from the Africa CDC event management system, and you can see the distribution of zoonotic diseases. And we know that zoonotic diseases present the risk for the next pandemic. And the question is not whether it will happen, it's when will it happen. So just to round up, lastly, I want to say that we need to adopt a One Health approach that does not just speak it, but acts it. Thank you very much.
All right, now we'll welcome Dr. Nathikunda.
Hello, everyone. Can you hear me? Good. So we have a challenge here, and I need to win it to keep in 5 minutes. And I have 10 slides. So please help me keep time by coughing or just give me a sign, right? We need to do this. So today I'm wearing the climate change heart. But in normal days, my current work is on solidarity. And all of you have been talking about collaboration, intersectoral working, and everything else. So in my free time, you can approach me and ask me what I'm doing on solidarity in global health. Interesting, right? Okay. So this is part of my work that I did while I was with my team at the London School of Hygiene. That was my previous work. Now I'm at Oxford. And we were looking at how national disease surveillance systems are incorporating climate change. And so I'll just give a very little background because this has been an ongoing research that we've presented even at previous conferences And we were looking at managing climate-sensitive diseases or transmission as a way of adaptation. Now we have NAPs, National Adaptation Plans, and there are very rapid movements happening. There's a lot of digital surveillance from the COVID-19. We don't know if the dashboards are still working, right? We had those dashboards set up online and everything. You can tell me the answer if they're still working or not. When we also have pandemic planning and preparedness of late, it is a hot cake too, right? I think if you know the disease platform or the disease discussions going on tropical diseases and climate change, you might agree with me that, yeah, most of the people are putting more money in pandemic preparedness. So before we get to pandemics is what we are looking at. How do we prepare for the diseases? How do we survey them? So last year, WMO, which is the World Meteorological Organization, it said 23% of the health surveillance systems were only using the climate data. Imagine that. So today, disease surveillance, we are just going to be looking at mostly identifying, tracking, and also investigating cases. But it has a response bit. So before we go to response, can we actually stop it from going to epidemic, pandemic status? So our research, like I said, we were looking at how disease surveillance systems can help governments to respond to climate change. And those are the three questions that we are looking at. First, we wanted to go to the literature and understand that we can get some evidence on current operational systems. Then we are going to go to our policies and climate strategies, and we have policymakers, which I'm happy here, and see how they're incorporating these documents or climate change is being put into the documents. Not just change, adaptation, using information. How is it being integrated? And then the third one, we did interviews with these key policymakers as well, but also international agencies. So the first phase, we went through all the NAPs across 14 countries. We started with East and Southern African countries. And these are the diseases that we saw, the list, that was prioritized across these 14 countries in East and Southern Africa. And the priorities specific on disease, infectious diseases were on integrated surveillance, they were on prevention, they were on public awareness, and also alert and response systems. So some of the results, and I've said this work has been presented at some earlier conferences, but just to catch you on what we had, only 5 papers qualified in our scoping review. 5 on current operational systems. But there were millions, over thousands of papers. We had 1,245 papers. 5 of them made it to the current. What does that tell us? The other papers are all pilots and they were closed and case done. Did we get any lessons? No. Are we building on those lessons? Maybe not. So researchers, let's look into ourselves, and funders, I think they have an idea. So also, in terms of diseases, malaria, meningitis, and Rift Valley fever were the only diseases that had some surveillance systems. These were only provincial, regional, and provincial status. Not lower level, not local level. Then in terms of evidence, what climate tools they are using, it was mainly precipitation, which is rainfall data, which is also land surface, which is temperature, then vegetation indices. Meningitis had, sorry about that, only surface data concentration included, and also some relative humidity. And then for the policies, the priorities we picked out were mainly in line with surveillance. And these are the priorities that we saw from the policies: strengthening surveillance systems, mainly at community and district-based, functional early warning systems, either establishing them or improving what's there, collaboration, and the rest. I know you're reading, so I'm not going to read everything. But these are highlights, and I hope you can engage me in maybe the question and answer. Now to the interviews. We didn't do many, but these were key informants. And you can see we have a little bit of national health decision makers, development partners, international agencies who are supporting that, and also some experts. But we wanted to know what else are we not seeing from the reports, the data that we can get from the people. And there was areas of limited use of climate data in surveillance systems, as my colleague has said, but we can tell that most of the data was coming data access, the National Public Health Institutes had more access to the Met side than Ministry of Health in some countries, but there's still challenges with access. Then there is progress in early warning systems, but these are mainly malaria predominant. And then we have adaptation monitoring. Indicators are still in the early stages, and this is what is happening, and we can see some people developing some of them, but we can engage more on what examples of adaptation monitoring are happening. And more findings are all on structures, on local evidence, on community level surveillance, and also capacity strengthening for public health professionals. So I want to pause here because my concluding statement will have this, and I hope that you can catch up with us. Thank you very much.
Thank you. Keep the notes and ask them questions so they clarify on more of those. I think there's a lot of interesting stuff. Because of time, I cannot allow them to go on and on and on. We need to interact with you guys. All right, I'll now welcome Didakas, who will be very short because he's just building up on Dr. Nakutinda's presentation, but now a case study from Uganda.
Thank you, Chair. Good morning, everyone. I'm building on what Dr. Natukunda has mentioned, the experience in Uganda. It's a case study. University of Oslo and a local NGO called HISP, Ministry of Health, and we are trying out